Good afternoon, all of you. Today we have Dr. Ravi Shah with us. A very warm welcome to you, sir. It's my pleasure to invite you as our speaker for today's webinar. Dr. Ravi Shah is an assistant professor in Sarvajanik College of Physiotherapy. Sir has done Master of Physiotherapy in Neurology. Sir is having more than 8 years of clinical and 7 years of academic experience in neurological condition. Sir is having more than 9 publications in different international journals. Today he will share his knowledge about hemiplegic gait with us. Once again, I am welcoming you, sir. We will start our webinar. Over to you, sir.
Right, thank you, Jigisha. I hope I'm audible properly right now.
Yes.
Right, so a very warm welcome to all those who joined this webinar. I'd just like to start sharing my screen right now because we don't have much of time to talk about things right now. So today's topic basically, I hope the screen is visible to all. Right, so
Yes, sir.
today's topic basically focuses upon hemiplegic gait, myths and facts about circumduction during gait. Now, there has been a lot of discussion on this topic over past years. Considering that circumduction is always supposed to be associated with a hemiplegic patient. Well, you need to have a lot of understanding regarding what needs to be done. And management of circumduction gait has been going on since a lot of years, or let's say a few decades, which has changed the entire scenario. But still, there are certain areas which need to be looked upon. So, management of circumduction gait is basically aimed at improving the balance and walking safety and prevent falls. Now, these have been the major areas of lookout for all the neurophysiotherapists to find out what are the strategies which can help improve the balance and walking safety issues and also prevent falls. So, the GAIT program, which is usually included as a part of rehabilitation protocol, includes muscle strength training, use of AFO, functional electrical stimulation, etc. So the major focus usually is always laid upon how exactly can we make the person more mobile and try to see that the person does not meet with any major traumas. So the discussion today is going to be primarily focusing upon what exactly is known to us. Right? So we know what is a typical hemiplegic postural alignment, what are the dynamic adaptations post hemiplegia, because we all know that once the hemiplegic patient starts adapting to certain kind of movement pattern, they already have started forming the new CPGs, what we already know as center pattern generators, and that is what leads to accurate observational finding of an awkward way of walking, or let's say translations throughout the space in which they move around. Now, the major deficits of selective muscle function during hemiplegic gait, I am definitely sure we all know about it, but that is one of the key areas which I'm going to be talking about today, because the primary issue with the hemiplegic patients is use of selective motor function or selective muscle recruitment. And last but not the least, understanding the facts versus the myths while treating hemiplegic gait, because usually till date, as far as I am concerned, I have been seeing that when treating a hemiplegic person for gait issues, we usually focus upon isolation training rather than focusing upon compound motions, which are actually a part of your gait. To continue with, following hemiplegic stroke, many people present with one or more clinically significant kinematic deviations of normal gait. So, in the first scenario, we should first be knowing what a normal gait looks like. So, if we are not falling in the wrong corner today, we usually identify the different phases in terms of two major categories, that is the stance phase and the swing phase. The stance phase usually has got heel strike, foot flat, mid stance, heel off in two of it. The swing phase has got early swing, or the acceleration phase, the mid swing, and the deceleration phase. Now, it is going to be a lot of it's going to take a lot of trouble for the physical therapist to look about in different areas which are affecting the gait, because gait does not involve one joint altogether. It involves right from your toe of the lower lip till the upper lip and the torso again. Significant kinematic deviations observed in swing phase include decreased peak hip flexion, decreased peak knee flexion, decreased knee extension for heel strike, decreased ankle dorsiflexion throughout the swing. Now, these are the primary areas which I'll be focusing upon today, and I'll try to clarify some issues regarding understanding which need to be implicated in the treatment aspect while treating gait protocols. Now, what needs to be addressed are the causes of these kinematic deviations in terms of the forces produced by the inappropriate activation and adaptive shortening of particular muscle groups. Like I said before, the primary issue post hemiplegia is not actually walking. It is basically walking using the right muscles or the key activation of the muscles in the right instance of time, because if the right muscles are not being utilized in the right instance of time, it is always going to be very, very taxing and deviating for an individual to manage gait deviations or gait protocol. Now, there are specific physical requirements for swing phase to be successful. So, if you start observing a normal gait, basically, you need to understand that the patient needs to be having a very decent weight shift right from the initial phase of gait cycle. If they are not able to shift the weight from one limb to other in order to swing one of the limbs in the forward direction in order to translate in space in whichever direction that they desire to, it's going to be a lot of trouble for them to manage to move about in the space around them. So the foot must be transported forward, the lower limb must shorten sufficiently to enable the swinging foot to clear the ground. The important kinematic characteristics which enable this to occur are: the first is hip flexion, the next is knee flexion, then extension, and the last one is ankle dorsiflexion. So once again, I'd like to draw your attention towards the primary areas which needs to be focused upon while treating a patient with hemiplegia. So if you were to be treating the patient with hemiplegia, the mechanics of normal gait usually is going to be providing a template against which the mechanics of hemiplegic gait can be compared. Now that is what we do, isn't it? We try to compare any sort of deviation with something what is already established as gold standard normative data. The kinematic deviations of the swing phase of gait commonly observed after hemiplegic stroke, either as a direct consequence of motor problem or as an adaptive strategy which is learned in order to compensate for the motor problem. So we need to understand that whenever we are talking about any or all kind of deviations, you need to bring in not only the actual motor issues what the patient is facing, but also a lot of understanding regarding the adaptive strategies which the patient keeps on learning if and when they're allowed to compensate for the motor problems. It is a well-known fact that if the patient with hemiplegia is referred to you in a very acute stage and then you are asked to manage the later on problems or the physical complications, it is very easy or it is a bit easier to predict the outcome because the patient is not going to be out of supervision and they'll be using any or all kind of motor strategies which are being taught to them. In case if the patient is not being supervised, there are a high number of chances that the patient will use all the compensations possible just to meet the consequences of not being able to recruit selective motor control. And that is exactly where they learn to compensate using a lot of motor deviations for the so-called missing components. Now, what you need to understand is there is a lot of change which comes after hemiplegia. Now, if you were to be comparing the hemiplegic gait to the normal gait, we all know that the person start using a lot of circumduction. They meet with a lot of issues transferring weight from the non-affected side to affected side and affected to non-affected side. There's a cross chaining of the stepping pattern what they use. There's a lot of deviation in the line of projection as they start walking. They start deviating from the midline of which they're supposed to be walking. Well, all of these basically can be related directly or indirectly with a lot of incidental, happening at different joints. So let us speak into what are the joints basically which we need to understand about, and then maybe we'll be going back to the treatment protocol. The first thing is decreased peak hip flexion in swing phase. Now, let me just clarify the fact when I talk about decreased peak hip flexion. The word peak hip flexion means the amount of flexion of hip which is required at the highest most level to produce a decent enough swing phase. So, we are going from proximal to distal over here. So, please try to understand when the patient is supposed to be translating the affected the right side hemiplegic patient is supposed to be translating by moving the right lower limb forward. The person will face a lot of difficulty moving the hip into flexion. Now, there are a lot of reasons behind this, but then the primary issues are inability to produce sufficient active tension with the help of hip flexor muscles in pre-swing or early swing. Now, please try to understand the patient needs to shift the weight from the affected side to non-affected side, which is in a good position to weight bear. So there should not be much of an effortful situation arise in case the patient has to move the affected side forward. But still, the patient finds it difficult to draw the lower limb forward just because, as we know of, the patient's posture post hemiplegia is typically seen to be in an extensor synergistic pattern in the lower limb and flexor synergistic pattern in the upper limb. Owing to this synergistic pattern in the lower limb, the patient loses the property of controlling the lower limb, wherein it needs to be dissociated at each and every instance of time of production of the gait cycle. And that is exactly where the lower limb does not have any capacity to break down at different joint levels. Now, what usually happens is the patient tries to move forward by using as much power they have left over to move the lower limb forward. But then what is happening actually is the patient does not have good amount of flexion at the knee, dorsiflexion at the hip, dorsiflexion at the ankle, as well as flexion at the hip, which is actually required to produce sufficient forward translation of the lower limb. So this is one of the primary issues where it actually begins to hurt the gait cycle in post-hemiplegic patient. There's also going to be decreased peak hip extension in late stance phase. Now we all know that the late stance phase requires a lot of extension of the hip where the lower limb is going to just get pushed off with the help of later extension of the knee turning into flexion, as well as dorsiflexion of the ankle getting converted into plantar flexion thrust. So at the hip level, if we start seeing, you have issues regarding both the incidences because the leg now assuming a state of a band. You know why we call it a band is because it does not have the capacity to flex and bend. The lower limb needs to be shortened in order to move forward. Just because the person loses the ability to sufficiently shorten the leg needs to be dragged forward, and the entire leg being dragged forward requires a lot of power coming from the hip flexor muscles. Owing to the awkward postural deviations, the muscles are not in a state of producing sufficient amount of tension to draw the entire lower limb forward. The counterpart, if in case there was a good amount of thrust coming from the ankle region, along with a good amount of flexion at the knee and the hip, again it would be easy for the person to compensate for the missing hip flexion component. But then both of these are seen to be totally absent in the the subacute phase where the patient is entering inside the spastic stage. So I hope by now everybody must have understood that circumduction is not a property of flaccidity stage. It is basically a property of spasticity stage gait cycle. Now, the next level of understanding should be coming from the knee. So there's going to be a decreased peak knee flexion in early swing phase. Now, as I told you before, if the hip has to be used effectively, it is always going to be requiring a good coordination or a timely flexion coming from the knee region. Inability to produce sufficient active tension with the knee flexor muscle in the pre-swing phase is basically one of the primary hurdles for the patient not being able to move the limb forward. Now, like I said, in case of hip flexion strategy, the patient needs to have shortening of the lower limb, and the shortening of the lower limb in the late phase of stance has to be coming with a lot of hip flexor activity in a concentric fashion. Just because the hip flexor activity does not have good amount of tension bearing capacity to counteract excess amount of tension which is being bared by the spastic knee extensors, as of we know that the extensor synergy primarily includes the calf muscle, the knee extensors. At the same time, they have got a lot of issues coming from the upper end. So coming down at the knee level, just because the knee extensors do not give up in time. Now please remember, these extensors are spastic. They are not strong or shortened knee extensors. So what is going to be happening is, because of the spasticity feature, the moment the lower limb tends to go into the late stance phase, the hip tends to go into a bit of extension, and extension at the hip also tends to extend the knee joint, which also leads to a lot of spastic catch coming at the quadriceps. Now, because of which, there is an inability to produce sufficient active tension with the knee flexor muscles in the pre-swing phase. and that again implied by leads to a lot of difficulty in exerting force coming from the hip flexion. You see, so both the levels are matching with each other and they are comprehending with each other, not to allow a smooth translation in the forward direction. The next point to be discussed at the knee level is production of excessive active tension with the knee extensor muscle in pre-swing or early swing. Now, again, the same point to be repeated over here. You need to have a good shortening at the knee joint in the early swing, which is usually brought about by active concentric contraction of the knee flexors versus active eccentric contraction of the knee extensors. But at the same time, in the pre-swing phase, when it is about to get converted into, the mid-swing phase, where the flexors usually start going from a concentric contraction towards eccentric contraction, because post mid swing the limb will be required to be taken into an extended position. That is what produces a good amount of stride length. So production of excessive tension with the knee extensor muscle in pre-swing or early swing basically is not actually aiding production of a good swing at the hip joint above, which is usually primarily on the initial side produced because of gravitational motions, gravitational moments. Now, because of production of active tension in the knee extensors, it will not allow that shortening phase or the knee flexor activation in the early phase, which otherwise is the prerequisite basically for pulling the knee later on into extension stage. Production of excessive active tension in the plantar flexor muscle at the same time, that is in the pre-swing stage, again is one of the primary reasons why the knee fails to go into flexion stage. You see, in case, if you can imagine a spastic hemiplegic patient standing in front of you, you'll be seeing or noticing that there's going to be an apparent lengthening noted in the affected side lower limb as compared to the non-affected side. And this lengthening is basically achieved or produced not because of some other reason, but because of the spastic contraction coming in the calf muscles, the anti-gravity quadricep muscle, and the higher region not comprehending with maintenance of tone or the length. So production of excessive active tension with the plantar flexor muscle in the pre-swing stage. Please remember, pre-swing is the stage of just post toe off, right? So post toe off, the knee and the hip is supposed to go for flexion, but at the same time, the ankle is supposed to be finishing the plantar flexor activity and going into dorsiflexion. So just because of production of excessive active tension with the plantar flexor muscle in the pre-swing, there's a lot of difficulty exerting something called as knee flexion in the early swing phase, and that again, if you can correlate, is going to be leading to a lot of difficulty in producing sufficient amount of tension at the hip flexor muscle in the pre-swing or early swing. The next point to be discussed is an adaptive shortening of the plantar flexor muscle. We have been trying to jot down a lot of reasons regarding why exactly is the plantar flexion not giving off. A lot of strategies of treatment have been decided, a lot of strategies have been planned and executed, but then almost everything fails because we fail to understand that over a period of time, not only does there happen to be a weakening of the muscle, but there's also going to be shortening, adaptive shortening of the plantar flexor muscles owing to prolonged positioning in the plantar flex state. Now, rounding up the entire matter again, if there is shortening of the plantar flexor muscles, what is going to be happening is when you go for heel strike, there's not going to be a clean heel strike in the first instance itself. If the heel strike is not available, there's definitely not going to be a foot flat. But usually, if the angulation of plantar flexion is manageable, these people or the hemiplegics, they maintain to let the entire foot straight away into foot flat. Now the question comes, what after foot flat? Because the plantar flexors have already gone for shortening. So if the tension allows, if the plantar flexion tension allows the tibia to move ahead over the talus, then there are chances that the patient might be able to clear off the mid stance or maybe till mid stance. But then again, if you start considering the late phase of stance, as of what we're talking about is the early swing phase, definitely yes, the ankle is not going to be allowing excess amount of translation, or the plantar flexor is not going to be allowing excess amount of translation of the tibia over talus. And that is very much required for the heel off and the toe off to be productive enough to thrust the limb forward later on. Again, the same reason is going to be leading to lack of a proper translation of tibia over talus, femur over tibia, and the hip over the entire lower limb. There's also going to be a relative decreased peak hip extension in the late stance phase. Now, why exactly is the hip extension getting affected is because most of these patients actually are found to be in a sitting state for the entire period of time. So usually there are two scenarios what we look into. The first scenario is where the hip flexors have gone for adaptive shortening. The other scenario is where they've gone for loss of usable length to exert a good hip flexion in the swing phase. Well, considering the first area, that is, there's going to be a reduction in the adaptive length of the hip flexors. That is what actually does not allow basically the hip extension to happen in the stance phase. And believe me, the hip extension is required to have a good amount of flexion, which is coming later on as a part of the swing phase. So if you consider the points what we have talked about so far, there's going to be a decreased peak hip flexion in the swing phase, and there's going to be a decreased peak knee flexion in the early swing phase, owing to a multiple number of factors what we've already discussed. Now, decreased knee extension prior to heel strike is the next area of interest. What is going to be happening is, because we are talking about a patient who is spastic, there's always going to be a debate, and it already continues actually, regarding an understanding that a spastic muscle is not a strong muscle. It is just a reflexive muscle which exerts a quick force of contraction, usually concentric, and then it just gives off, which is also termed as a Glass-Knife phenomenon. Now, why are we talking about knee extension right now is because when we talk about circumductory gait, we should know why exactly is circumduction coming in. Well, the decreased knee extension prior to heel strike basically is a notice that the knee extensors again are not under voluntary control. They are not under selective motor control to be executing a good amount of heel strike. Now, why exactly does this take place? Inability to produce sufficient active tension with the knee extensor muscle in the early swing, right? Now, what was the tension which was required in the early swing phase? You're actually supposed to go for an active eccentric release of the knee extensor because you want the limb to shorten up so that the entire lower limb can be brought in the forward direction post mid swing to have a good stride length produced at the affected side lower limb. But now, just because of increased amount of tension in the knee extension phase, the knee might fail to actually give up in the early swing phase, and that is what might again hamper the good tension capacity or good area of pull of the extension mechanism coming from the quadriceps. Production of excessive active tension with the knee flexor muscle in the swing. Now, this is one more debate what usually goes on. So, if the knee extensor synergy pattern or the extensor synergy pattern exists in the lower limb, how come we are talking about knee flexor muscles creating excessive tension in the swing phase? Well, we need to understand one thing, that if the patient is found to be in spastic stage, whenever they are seen to be resting, they are usually lying down in supine, or maybe they are seen to be in sitting postures, and which is one of the prerequisites for getting knee flexor tightness or shortening. So basically what happens is, it is because of the adaptive scenarios what the patient goes through, or the patient selects to go through, or they're imposed to go through. There's a lot of mismatch between the length tension relationship of the muscles which are actually usable, at the same time the muscles which are not usable or are out of selective motor control. Hence, it is the production of excessive tension with the knee flexor muscles in swing which does not allow, again, a sufficient lock at the knee joint, what is supposed to be produced by a so-called spastic knee extensor muscles. That is exactly why you might be seeing that most of the patients with hemiplegic gait or spastic hemiplegia, they actually land up with two scenarios. Either at the stance phase, when they have to go through, they end up with a mild buckle, or on the entire contrast side, they end up with a lock, knee joint. So depending upon which muscle out of the extensor or the flexor component is over dominating, you might see either of these scenarios. At times, it has also been seen that the patient actually locks the knee and suddenly buckles. So all these interplay between the muscle tensions is what creates a very awkward situation for the patient to use a near normal walking gait cycle. So despite of using a lot of efforts to see that the limb does not sway out or the limb translates forward in a normal or neutral direction, because of or owing to all these muscle tension issues, they are not able to go through the entire cycle in a decent phase. Adaptive shortening of the knee flexor muscles or a loss of compliance of other tissues of the flexor aspect of the knee are basically one of the primary responsible factors which will not allow the patient to use whatever strength they do develop in the knee extensors later on. You see, as the patient starts recovering, and if we can just recall the brainstem stage of recovery of post-stroke, we already know that patient starts losing spasticity as the brain, starts recovering in case they do. And there's going to be a lot of conditioning coming from the treatment protocols, what they're imposed to, which is going to be helping the patient start recruiting selective muscle tissues and have a good control over the lower limb while walking. But then just because of, again, as I said, being imposed upon with a lot of adaptive shortening of different muscle groups, they lose the compliance of other tissues, and that is exactly why the compensations start coming in. Now, there's also going to be a decreased knee flexion in early swing. I think we have already talked about this before, but still, why exactly is there a decreased knee flexion in early swing is because the extensor of the knee joint is basically hyperactive. Owing to the hyperactivity of the knee extensors, just because the patient tries to go into the late phase of stance, which causes hip extension, causing knee extensors also to be stretched. Now, please bear in mind the knee extensors, what we are talking about right now, also have the secondary property of flexing the hip joint. Hence, the late phase of stance or the early phase of swing, when the hip actually starts translating into extension phase, the hip flexors basically are being pulled back, and that is what leads to a taut impact upon the knee extensors also, which are the secondary flexors or accessory flexors of the hip joint. So I hope the concept is clarified right now. Why exactly is every muscle acting as per its own wish and will? Well, the reason basically is the positioning of relative joints on which they are acting as per different phases of gait cycle. Now, there's going to be a decreased dorsiflexion in the swing phase. How exactly do we relate dorsiflexion in the swing phase basically? Well, we all know by far that the plantar flexors are the ones which are the culprits at the ankle joint, not allowing the ankle to rest in a neutral state or maybe to go for a selective active dorsiflexion. In case the patient does initiate a good amount of dorsiflexion using the tib anterior, that is tibialis anterior, or maybe extensor digitorum longus or hallucis longus, it always remains a troublesome fact for them to initiate a good neutral placement of the plantar surface of the foot, because we all know far that the spasticity in the lower limb always brings with itself not only ankle plantar flexion, but it is also going to be associated with ankle medial deviation, that is inversion, or in other terms, people call it a supinated foot. It is because of the supination of the foot associated with the plantar flexion at the ankle, there's a lot of trouble because the late phase of stance, as in the gait cycle, is always associated with a push-off phase. The push-off, which is otherwise called as the heel-off to toe-off phase, and the heel-off to toe-off phase is always associated with a very strong inversion getting converted into eversion at the subtalar joint. Just because the later phase where the ankle or the subtalar joint is supposed to be pushing itself from plantar flexion to dorsiflexion, which is not being achieved because of a strong plantar flexion attitude at the ankle joint, owing to the spastic nature of the lower limb, been associated with a strong pull from the medial aspect of the foot. That is basically coming from the plantar flexors and medial rotators, or not rotators, basically deviators. That is, tibial is anterior along with tibial is posterior. There is an inability to produce sufficient active tension with the dorsiflexor muscle in the swing. So this concept has to be understood in terms of how exactly does lack of active dorsiflexion affect the swing phase. Well, we all know that if you have to land with a good heel strike, you definitely need to have a decent dorsiflexion coming in at the ankle joint. But then, what we are talking about right now is post toe off phase. That is what happens after the toe off. And that again brings us to an now, in the swing phase, you need to understand that we are precisely talking about the early swing phase. Well, as I told you before, if you want the early swing phase to happen properly or in a decent fashion, you should have a good active hip extension, a good active knee extension, along with a good amount of dorsiflexion coming at the ankle. This is what marks the initial prerequisite of a good and decent forward translation of the lower limb, which is otherwise termed as a swing phase. So precisely, we are talking about the phase of heel off to toe off right now. Just because the patient does not have good amount of dorsiflexion in the swing phase, or let us put it as the early swing phase, the patient loses the capacity to generate the thrust, which is otherwise supposed to be coming at the late phase of stance, and push the lower limb forward. Now, of course, we are not looking at the weak dorsiflexors or the strong plantar flexors themselves as the culprits over here, but you also have a bad knee, a bad hip. Well, they are not having good amount of flexion and extension coordination in both the levels, and that again is combined with the so-called strong plantar flexor pull or a weak dorsiflexor pull at the ankle joint. Now, production of excessive tension with the plantar flexor muscle in swing is basically what is troublesome, because we all know that the entire concept of swinging the lower limb rests upon shortening of the swing side lower limb. In case if the swinging side lower limb does not bear enough amount of resources to flex itself or shorten itself, there is going to be a troublesome time phase while executing mid-swing. Then we also have the same scenario going on with foot drop cases, and they usually compensate very easily by using something called as a hip height, or maybe something called as a high stem edge gait, which is later on followed by a slap, right? But in case of hemiplegia, as of the spastic phase regarding which we are talking right now, we cannot expect such kind of phenomena to happen. Why? Because you have the entire lower limb being born in excessive amount of tension, which is spastic. Because of spasticity, the entire shorten while the early swing phase has to begin. And definitely, yes, it cannot be dragged forward without making certain compensations. Well, coming to that later on, adaptive shortening of the plantar flexor muscles is one of the primary inhibitors. And definitely, yes, even if the patient wants later on to walk with the help of splints and AFOs or orthotic aids, it becomes very, very difficult because there is no lending of the heel inside the so-called orthotic aid what has been described or prescribed to them. So please try to remember, patients need to have a good amount of shortening coming at the lower limb. Now, why exactly? Let me just quickly rush through the four. So I hope the screen share is active right now and I'm audible properly. Right, so you have got a decreased peak hip flexion in swing phase. You have a decreased peak knee flexion in early swing phase. There's a decreased knee extension prior to heel strike and decreased dorsiflexion in swing phase. Now, why exactly did we discuss all these things in details is because we need to come to something called as myths about circumductive gait and how exactly are we supposed to be implicating the so-called understanding what we are going through right now as a part of the treatment protocol. I hope we have time left. Now, if you were supposed to be talking about how exactly does circumduction come in, well, there have been a lot of myths regarding circumduction that the patient loses the concept of walking. The patient has got pusher syndrome. That is why the patient is pushing excessively to compensate on the the non-affected side. The patient has lost the proprioceptive feedback coming from the lower limb on the affected side. That is the primary mediator of circumduction. But then we need to understand that it is not only the sensory component or the organization component what is affected. There's a lot of motor aspect to it. So if you were to be treating these individuals, you first need to understand what exactly is happening while circumduction is being adapted to. Why does the person need to circumduct? And is it so that right from the initial phase of spasticity, incoming, the person starts adapting to circumduction? Well, definitely not, because we see a lot of hemiplegic spastic patients, let me specify clearly, walking without circumduction. Well, how is it possible? Well, we have seen a lot of complex issues regarding the hip flexors and the hip extensors, the knee flexors, extensors, and the ankle mediators. By now, we must be understanding that the primary reason for not adapting to a good gait pattern post-stroke basically is because of lack of ability to dissociate. Now, why exactly do we use the word dissociate? Is because by dissociation, we directly or indirectly mean that the person should be having a selective motor control of producing inhibition and facilitation of muscle which are required in time to produce the required moments or angular patterns at different joints. We also have a concept of pivoting on the non-affected side while the patient needs to circumduct and bring the limb forward. So let us go to the compensations or the deviations what the patient starts getting adapted to because of the so-called mechanisms what we have seen so far. Well, if the patient fails to shorten the limb while walking, what we'll be seeing is that the patient has a lengthened limb on the affected side. Now, having a lengthened limb itself brings in the concept of limb length discrepancy, where one side, that is the affected side, let us put it as right lower limb right now, is seen to be lengthened. I think I don't have anything to share right now. Right, so
Okay, thank you so much, sir, for accepting.
uh,
Yes, sir.
I still have some things to be talked about. I was just stopped my presentation right now, so I'm sorry if I got misinstructed. So now the main concept is that the patient has to get adapted to some of the other kind of features so that the patient can work, because primarily each and every hemiplegic person wants to work. So now the entire cyclic process of so-called adaptations or compensation comes into the play. You need to understand first that the drive to walk basically is what is promoting the patient to use whatever forces they have to translate in the direction which they wish to or they desire to. So the primary thing what is required is clearance of the affected lower limb, and that calls in for an increased hike at the affected side. But let me clarify one fact that we already have a limb which is lengthened at the ankle, so the hip on the affected side already is in a hike. That means the person has already lost the chance of using one compensation of hiking the lower limb or hiking the hip on the affected side to draw the lower limb forward, which would otherwise be possible in case of something called as a foot drop gait, where you can dissociate the hip, knee, not the ankle, of course. So, if you try to compare the gait cycle of a hemiplegic with a normal individual, we see that the gait cycle of a hemiplegic does not actually begin with a lateral shift on the non-affected side, but it actually begins with a lurch on the non-affected side or a lean on the non-affected side. Why? Because primarily the patient has already lost the length which he or she could have attained on the affected side lower limb by hiking the pelvis. Hiking is done. Any more compensatory lifting of that side limb is going to be calling in for lurch on the non-affected side, and that is the first phase of circumduction mind well. Because of the lurch what the patient gets to do on the non-affected side, there is a lateral shift of the center of gravity and the line of gravity excessively on the non-affected side. So if I have to demonstrate that, I hope I'm visible right now. The patient has to stand like this. So if you can see properly, there's already a lot of weight shift on the left side, and the line of gravity which was supposed to be in the center has already shifted to the non-affected side. Now, if the patient has to draw the affected limb forward by any means, the only chance possible is to go for a sudden jerky motion bringing the lower limb in the forward direction, which is appropriate just because any more lateral deviation on the non-affected side is going to call in a fall. So what they do is, that is where the concept of pivoting basically comes in on the non-affected side. The patients start using a lot of pivot. They are pivoting on the head of the femur by actually mediating the pelvis over it. So it's like the glenoid cavity, the acetabular cavity is basically moving over the fixed femur. Usually what happens is it shifts on one side and then the foot translates forward, the leg translates forward. But in this scenario, what usually happens is the patient with the high pelvis, and then they are going to be just walking forward. Again, please remember, landing with the plantar flex foot, it is not a neutral or dorsiflex foot. And this is exactly why a lot of time the treatment is haphazardly going in the wrong direction, because all we do is treat the so-called symptoms. We treat spasticity or tightness of the calf muscle, or spasticity of the gastroc, or spasticity of the quadriceps, or maybe weakness of the iliopsoas, but then we fail to understand walking or gait cycle is not a chunk. They don't happen in a chunk, they happen in a continuum. There is a continuous phase of translation of each and every joint which needs to be addressed. So whenever treatment has to come in, it always has to bring in compound motions while treatment, more amount of translations while treatment, rather than going for isolated movement training. So with this, I would like to conclude the following presentation, or the ongoing presentation, with the idea that the myth about circumductory gait is that it's a stamped pattern of walking with hemiplegia. No matter whatever kind of hemiplegia we are seeing, whatever level of spasticity we are seeing in the patient will definitely end up with a circumductory gait. That is a wrong myth. You need to correct your understanding from the present presentation. I hope it was fruitful enough to understand that you need to treat the pattern because brain understands pattern. It is just because a wrong pattern was adapted to in the early phase post-stroke without supervision. When the patient starts walking, the quote says neurons which fire together, they wire together. So if the patient started learning a wrong pattern in the initial state to walk, a wrong firing pattern of muscle, a wrong technique of utilization of the motor control, whatever they are left with post-stroke, definitely they'll be landing up with the same pattern throughout the life, and that is what is very, very difficult to break through. So I hope the presentation has clarified the idea that we need not work on isolation basis post-stroke, especially when it comes to circumductory gait, and it will be helpful for you to understand what are the components that you need to look into, and then maybe decide what to do. Thank you.
Okay, thank you so much, sir, for sharing your knowledge regarding very sensible area of neurological condition, that is hemiplegic gait. Thank you so much.
Thank you. Are we on for
Yes.
some questions? Are we done?
No, sir. No more questions.
All right. Thank you. Thank you. Thank you.
Thank you, sir.